Now, for rotations, not so bad. Rotations can only happen a few places. There is some minor pronation, supination happens at the foot. I'm not going to bother with that because it doesn't really matter for you. So, internal rotation, external rotation of the hip. Internal rotation, well, external rotation. Not too bad. Now you can use the toes as a marker here. If somebody's standing, it's like how much of a pigeon are you versus how much of a duck are you? Are you part pigeon, part duck? I don't know. So, if you see that though, we're in external rotation. If you see this, we're in internal rotation. An easier one, initially, if we were to break this down individually, would be to bend one leg and then look at it this way. And this can be a great way just for like warm-up related things, for getting this freed up for knee extension, going into these kind of patterns, try to warm up the patellar tendon, all that, and then you can go into another one where you're doing single leg balance plus hip rotation. Now, this is very easy to assess on table. When somebody's laying prone, that's what I'm doing. So I'm assessing that hip rotation. Now, hip rotation could also be here. So I could lay somebody supine and be pivoting them like this, right? It's remembering that you need to think about what the femur is doing, not what the foot is doing. So this is external rotation of the hip. This is internal rotation of the hip. And I'm a good example of most people will get stuck at the hip in too much external rotation. And they should have more internal rotation. Where those muscles live are right under the gluteus maximus, back here. We've talked about those and how to get on those. Finding that greater trochanter, they all attach onto the greater trochanter. So I find the greater trochanter, move posterior to that, and I got them. And there's 6 of them back there. So start relatively high, and they go really low. I mean, they go low. They all attach onto that trochanter. So if you use that as a base of operations, then you can search and find stuff. And then that's that sciatic nerve. That's why piriformis, which is the most famous one here, gets identified with sciatic nerve related stuff. But those are the deep lateral rotators. Lateral rotation, external rotation. Synonymous. Lateral, external. Same. Both terms get used all the time. I tend to use internal, external, lateral, and medial is totally fine too. Where would the medial rotators or internal rotators of the hip be? That's an odd one. It's not the adductors. Well, no, what could it be? It's this stuff right here. It's kind of front of your pocket muscles. Go right here, find greater trochanter, and then just go just above it and anterior to it. And they live there. It's gluteus minimus and medius, the anterior fibers of those, and tensor fascia lata. So it's easier to show tensor fascia lata. Now, it's involved with a couple things. It's involved with hip flexion, but when it shortens, and it's visually, this one helped me of seeing how the deep lateral hip rotators are more posterior and then kind of just come around and see how that tensor fascia lata is more anterior. Gave me a good reference point. So usually this ideally would be a little bit stronger, but usually it's strong because of hip flexion. Ends up being important to get both. We're going to help somebody related to hips. Boom, boom, you got it. But that's where the internal rotators live, is there, okay? The shoulder, it's actually a little bit easier. If we're going to assess it, then, you know, a person's body can get in the way. And we want to try to make sure you're identifying just the shoulder and not the rest of the arm. So if I have a person just do this, or especially this, it can be hard to know what's moving. You're ideally just looking at what the humerus is up to. But if they pronate and turn their wrists in a particular way, that can make the assessment more difficult. So easier, in my opinion, to start to bend your elbows, okay, and then do either a rotation here. So this would be internal rotation, but usually the body gets in the way before we kind of see most, but that's 45, that's more than 45. So if we can go from here to touching our chest and our tummies, that's functionally pretty good. Right? That's what I need to be able to eat. So functionally okay. And then external is going to be the trick here. It's because most people are going to be too strong and tight here. They're not going to have enough here. And then you could see an asymmetry. Say like I exaggerate. This one's further out, beyond 45 degrees. This one's limited. I would make sure I assess. It's easier to assess on table. That's not a hard end feel. And I go, oh, the internal shoulder rotators here are too tight. The internal rotators though, I did not grab my rotator cuff, but that's okay. The internal rotator, the main one, is underneath the scapula. So rather than initially showing you how to go after that, which is a journey, if I ever want to be cruel just to be cruel, it's doing a subscapularis release, right? But we don't necessarily need to go there. We need to make sure we get the scapula mobile so that this ends up being freed up with it. Usually this gets stuck to stuff underneath of it. But this muscle, this big one that you'll see on the side, and occasionally in some bodybuilders, you'll see that ribbed kind of quality on the sides of their ribs. That's called serratus anterior. And what it actually attaches to, like it doesn't, what would it do here? Just, It does not move the ribs. It can be involved with respiration, but it attaches onto the scapula. It does protraction. This one I showed you. So this muscle here on the lateral side of the body does protraction. This muscle that sits right on top of it does internal shoulder rotation. Most people are stuck in protraction and internal rotation. That's why it's important to find a way to work here. And as long as we work along this line here and free up this space, that can usually get us a good rest of the way. And then we can maybe pin some structures and have a person do some active movement to strengthen the external rotators, which right relative to the rotator cuff, it's this one. This one makes a lot of sense in terms of actions. This is the internal rotator, that's the external rotator. Okay? Now with shoulder assessment, another option can be bring their arms out into a B-duction. Now we can get maybe a better gauge on internal and external rotation. They do not need to be all the way to 90 degrees. It can be more like 45, and then just how far can they go this way? How far can they go this way? So if I'm going to exaggerate my pattern, I can pretty much get this palm where it's fully saying, saying how do you do, but this one's tipped down. I think from an assessment standpoint, sometimes this is easier for you visually because you go, oh, that one is hypomobile. It's restricted. And then on table, that's easier to accomplish. You can do all the shoulder movements in sideline, but this one's really easy in either prone, with the arms off at the table, or in supine. Right? So again, internal rotation, external rotation, or medial rotation, lateral rotation, not name bad. The last one we get to, and spine stuff, it's not too bad. Right rotations, left rotations, all that. Now, the coupled action there should be that between the two, here to here, I can look behind me. Now there's some hip activity that will occur with this too, but ultimately, if I look for kind of a cheat, it'll be that. If I kind of do like a nice slow turn for me, look behind you, and go the other way. Does one feel harder? And I have to identify which part of that feels harder or looks harder to do. If you watch me, I'm exaggerating my asymmetries. Going to the right, not a problem. Going to the left, if you're standing behind me, like this versus, right? It's a pretty clear difference. Now what's actually happening for me there is my neck. I can get myself, yeah, there you go. But then you'd have to determine through more isolated actions like the neck stuff, okay? Over my shoulder, not over my shoulder. Okay, that's your rotations, not too bad. Lumbar here, where it should feel like we can get our belly buttons at 45 degrees relative to our greater trochanters. That will be a little bit easier sometimes, like watching a person, but that's a couple of movements that can be a bit more difficult. So that's where on table, that can be a little bit easier. And it can be as simple as taking, before you put the big bolster in, right? That could be hip adduction, as well as like how much of a twist there is that's comfortable for the person, and just seeing how symmetrical that looks compared to when they're on their other side. Okay. Also, why I rock people back and forth when they're in prone is to feel how much rotation is happening there. Does it feel like it's able to do a wobble more easily this way versus that way? And that'll tell me what the lumbar vertebrae are up to. Their neck can be real easy on table because they can just, like Sandy was doing the stuff on my head, they can just put their cheek on one side of the face cradle and their cheek on the other side of the face cradle. Hey, that's pretty good. You able to do that without screaming? I say we're doing okay. All right, the last one, pronation supination. Where that matters is here. So you're in anatomical position, you're already supinated, you can already ask for more soup. It's not the place for good comedy, but soup, supinated, sun, soup, supine, supinated. Yeah. Nobody lays like that. How do they lay? How do they tend to stand? They're out of supination. They go into pronation. So prone, pronation. Not hard to remember the terms. It's just remembering that we start with this as anatomical position, but it's not the natural posture people are in. They tend to get pronated. And this is an easy one to assess because you just look at which back of the hand they can see and which palm you can actually see. Somebody standing there like this, that tells you something, right? Then the question is, where is it coming from? Because it could be the shoulder, or it could be just the wrist. But it still tells me something, real fast in a quick assessment. Which hand is turned over, which hand is more up. Easy peasy. But assessment-wise, there you go. Can they supinate? Where it's at least palms to the ceiling, and then pronate. And does one of those feel or look more difficult to do? Not too bad. Identifying where that movement is actually occurring is the nifty thing. And then just watching the bones of the radius and the ulna. It's the radius that's pulling that off, okay? So when I pronate, here's anatomical position. When I pronate, that's happening. So the wrist is just coming along for the ride. See that? So you have muscles called pronator and supinator. They're not named so bad. Sometimes they're named normally. And you have 2 pronators for 1 supinator. Guess who wins? And where would the pronators be? Would it make sense for the pronators to be back here or to be here? Yeah? Anybody? Which one's doing that action? This one. So the pronators are here and here on the anterior side of the forearm. Now going after this one, you got to be careful. But up here, that's where another secondary piece of like where all these muscles are, got all these muscles sitting down on top of them, and makes sense that it all gets just glued together here in a person's, essentially glued into wrist flexion, pronation, and a little bit of elbow flexion. It's kind of all just gunked up. And then where right here, supinator, and your bicep brachii actually is involved with supination a bit too. So it's not completely by itself. But that's right there. All the extensor muscles go over top of it. So you can always find like a sensitive trigger point here somewhere on the posterior side of the upper forearm. And you're probably mashing on supinator a little bit. So that's a rotation pattern that's named differently, all occurring in the transverse plane.